move on to treatment aspect. Okay, so if you divide the overall therapy, you can divide it to something called prophylactic, preemptive, empirical and targeted therapy. Okay, each one is very important, so you have to know about the therapy. So when it comes like prophylactic, so patient is having a risk factor for developing Candida infection, so we don't want the patient to develop the Candida infection, so that is called prophylactic. Okay, preemptive, patient is having some risk factors, along with that we have done some screening method, maybe like 1,3 beta D glucan. So screening method is positive, then we start them on antifungal, that is called preemptive. Empirical, so we know that patient is having a Candida, so but we don't have a definitive like species identification, so then we start the therapy, that we call it as empirical. Targeted or definitive, we have the culture report in our hand, which species also we know. So this is about prophylactic, preemptive, empirical and targeted therapy. So again, so what is the IDSA recommendation when it comes to option for therapy in patients with Candida infection? So a Cochrane systemic review, which included near about 12 RCTs, near about 1600 patients. So prophylactic usage of antifungal in terms of mortality outcome. So we can use fluconazole 800 milligram followed by 400 milligram. Alternatively, we can use echinocandins or polyenes like amphotericin B. So daily bathing with a chlorhexidine is going to reduce the burden of fungal infection, particularly Candida. So till now, so we can use fluconazole for prophylactic option. Okay, so other alternative, depending upon the risk factor, you can go to echinocandins or polyenes. So again, when it comes to empirical and preemptive therapy, there is no much difference, because in the preemptive we have the risk factor, along with that one screening method is positive. Empirical, we are bit sure patient is having a fungal infection, but we don't have the definitive culture report in our hand. So we have to remember 12-hour delay in starting empirical antifungal is going to increase the mortality by about 200%. So significant mortality. You have to be very careful. Start empirical therapy as early as possible. Okay. So there are certain risk factors you have to consider when choosing an antifungal for empirical or preemptive therapy. Suppose if the patient was received azoles previously, the patient is neutropenic, unstable hemodynamic, so then the option is echinocandin. This is the IDSA recommendation. Okay. So other than these risk factors, you can go for so fluconazole or amphotericin B. So neutropenic, previously received the azoles, or if the patient is having unstable hemodynamics, option is echinocandin. This is about empirical and preemptive therapy. So again, one question is like, you started empirical therapy, when to stop the empirical therapy when it comes to Candida infection. Okay, if the patient improved, continue for 2 weeks. If the patient not improved, stop. If the patient not improved, no clinical response, in 4 to 5 days. Okay, you started on echinocandins being an empirical therapy, but no response in 4 to 5 days, then you have to think, so Candida is not the culprit, then you have to search for something else which is bothering the patient. Okay, so otherwise, when to stop? No subsequent evidence of invasive candidiasis after the start of empirical therapy. Have a negative non-culture based diagnostic method. So we have done some other modality of the diagnosis which came negative, then we can consider stopping the empirical antifungal. Okay, so if improved, continue for 2 weeks. If no improvement, 4 to 5 days, you have to revise and you have to consider stopping the empirical antifungal therapy. So coming to definitive therapy. Okay, I told there are some risk factors you have to consider for definitive, empirical and preemptive therapy. When it comes to definitive therapy, so when we have blood culture showing Candida in your hand, or you got some information from your microbiologist, patient is growing yeast in the blood, first thing you have to do is remove all invasive lines. Okay, do workup for some sort of septic thrombophlebitis or infective endocarditis. So exclude any hidden fungal abscess. So exclude invasive candidiasis, particularly you do fundoscopic examination to look for endophthalmitis. Okay, So then you start the antifungal therapy. Remove the lines, do some workup for infective endocarditis, see for any hidden abscesses, okay, and exclude endophthalmitis. So what is the therapeutic option? Again, the choose of your antifungal depends upon if your fungal infection is with Candida glabrata and cruzi, if the patient is unstable hemodynamically, if the patient is neutropenic, and if he already received azole therapy, option is echinocandins. Okay, so if any of these criteria satisfied, go for echinocandins. Otherwise, you can choose maybe polyene, amphotericin as an alternative therapy, or you can go for fluconazole. So this is about definitive therapy. Again, anudula fungin versus fluconazole for invasive candidiasis is a double-blind non-inferiority study. Near about 245 patients with invasive candidiasis they included. Overall response rate was significant higher with anudula fungin than with fluconazole. So it was significant. So 80% response versus 67% when you compare echinocandin, that is anudula fungin, versus the fluconazole. Superiority of anudula fungin over fluconazole was most distinct in patients infected with Candida albicans. So it's about 80 versus 62% when it comes to anudula fungin versus fluconazole. Definitely, so echinocandins are the option if the patient satisfies with some risk factor. So again, so among the echinocandins, which one to choose? So there is some comparative study, mica fungin versus caspofungin versus anudula fungin to treat fungal opportunistic pathogen, that is Candida glabrata. So near total 30 patients with Candida glabrata they included. Anudula fungin showed a bit better in terms of MIC requirement and therapy wise. In vivo studies, no significant statistical difference was observed. So it is an in vitro data which suggests when you compare within the echinocandins, anudula fungin is bit better, but in vivo, in the field level at the bedside, there is no much difference. So again, like if you compare all these three available echinocandins, okay, anudula fungin versus caspo versus mica fungin, there are some advantages of each and everything. So major advantage, if the patient is having a liver dysfunction, so caspofungin is not the option. If the liver dysfunction is child pug B or more than B. Okay. So when it comes to bolus dosage, you don't require mica fungin to give the bolus. Both anudula fungin and caspofungin they require some sort of bolus dosage. Protein binding is less with anudula fungin as compared to caspo and mica fungin. So these are some advantage, marginal disadvantages when you compare mica fungin, anudula fungin and caspofungin. Again, so suppose you started some sort of definitive therapy, how to de-escalate the antifungal therapy. Okay, so if you get sensitivity for particular antifungal, you de-escalate according to your sensitivity report. That's how we do for antibiotics also. So after 14 days of last negative culture, you can consider de-escalating, that is stopping the antifungal. So de-escalation means narrowing down your spectrum and stopping the antifungal. So as per the sensitivity, you narrow down the therapy. If you get a negative culture, from that day to 14 days, you have to stop the antifungal. If clinically stable, after starting definitive therapy, after 5 to 7 days, you can consider de-escalation from echinocandin to azole therapy. Okay. So these are bit important like approaches when you consider stopping or narrowing down the antifungal treatment. Again, a bit on Candida endophthalmitis treatment. So patient with Candidaemia should get one ophthalmological examination within first week of diagnosis. So the therapy is always with polyene, that is amphotericin B, with or without your flucytosine, because the penetration of your endophthalmitis with echinocandins is very poor. So you can give intravitreal like voriconazole and all, but always the therapy first line is amphotericin with or without flucytosine. Remember, echinocandins are not the option for tissue penetration when it comes to Candida endophthalmitis. Again, so question is about removal of central venous catheter. So there are lots of consistent data which suggest without catheter removal, when you suspect some fungal infection or when you got definitive culture positivity, 82% had persistent infection. It's very important, pull out the center line when you have a definitive diagnosis of fungal infection. So which shortened the duration of fungemia, so from 5.6 days to 2.6 days. So definitely, so the fungemia, the duration came down. So reduced mortality, it was 41% if you are not removing the line, against 21%. It's almost 50% reduction in mortality if you taken out the center line when you have a definitive diagnosis. Especially it is true for Candida parapsilosis. I told Candida parapsilosis is most commonly associated with central line related Candida infection. Very strong link with catheter, that is for Candida parapsilosis. So a bit on Candiduria. Many times we'll get Candida in the urine. Okay, what to do for that? Okay, asymptomatic Candiduria, no need to treat. This is the IDSA recommendation. So eliminate the predisposing factor. Remove the Foley's catheter. That's more than sufficient. Okay, but if the patient is having some risk factor for dissemination, okay, so if they underwent some urological manipulation, if they done some instrumentation for them, a short course of fluconazole is recommended. Even we can go for amphotericin B also. Neutropenic patient in low birth weight neonates, we have to treat them as equivalent to that of invasive candidiasis. Okay, so consider doing some imaging and exclude some anomalies if the patient is neonate or pediatric age group. So Candiduria asymptomatic, don't bother. Okay, just change the Foley's. Symptomatic, okay, we have to treat with the risk factor. If they are neutropenic or like low birth weight, definitely they require therapy like invasive candidiasis. Okay, again, last part, when it comes to antifungal, you have to know some idea about where your antifungals are going to act. Okay, if you think, see, polyenes, that is amphotericin B, and azoles like fluconazole and voriconazole, they act on cell membrane. Your echinocandins are going to act on your cell wall by inhibiting 1,3 beta D glucan synthesis. All your echinocandins, cell wall. Azoles and polyenes like amphotericin B, they act on cell membrane. When you choose combination therapy of the antifungal, you have to choose like antifungals which are having a different target, different mechanism of action. Okay, that you have to remember. Again, this is the overall development of antifungal over a period of like 5 decades. Initially, we have started from nystatin. So now we reached up to echinocandins, including caspomycofungin, voriconazole, posaconazole. These are the second generation and third generation azoles. We have extended generation azole, that is isavuconazole, which is in the pipeline. So which already FDA has been approved, but we are waiting to make it available in India. So this is the overall spectrum of activity of the antifungal. So if you see echinocandins, they are having a good activity against everything except your Candida parapsilosis. Okay, if you see azoles, they are having a limited activity against Candida krusei and Candida glabrata. Okay, when you get Candida krusei and glabrata, azoles are not the option. Okay, when it comes to Candida parapsilosis, option is azoles. Okay, these are some key factors you have to remember when you choose antifungal agent. Again, is there some benefit of combination therapy? Some data is available. Okay, they used fluconazole with amphotericin B, so showed some benefit, but no mortality of outcome benefit. But maybe in some areas like decreased requirement of the antifungal days and all, but outcome benefit is not with some combination therapy when it comes to invasive candidiasis. So can we use some adjuvant therapy for invasive candidiasis? So there are some randomized double-blind multicenter trial conducted in US and Europe. Near about 120 patients they included with invasive candidiasis. They used some lipid-associated amphotericin B with efungamab. Okay, so efungamab, it's a monoclonal antibody versus amphotericin B alone. So ampho with efungamab. So how it's going to act? So it's going to enhance the activity of amphotericin by binding to each shock protein 90. Okay, so you have to remember, so something is happening in terms of adjuvant therapy when it comes to treatment of invasive candidiasis. So one study, that is efungamab, it's a monoclonal antibody, they use it with amphotericin liposomal, showed some benefit. Again, so this is the overall picture of toxicity. Just go through this slide. Okay, each and every antifungal except echinocandins, they are going to have some adverse effect. Okay, amphotericin B like nephrotoxicity, renal tubular acidosis with dyselectrolemia and all. Voriconazole drug interaction, difficult to maintain the level. Okay, photophobia, skin manifestation, transamenities, some peripheral neuropathy. So all these are some named adverse effect when it comes to antifungal selection. So you have to be a bit clear on which species they are going to cover, organ penetration and adverse effect when it comes to antifungal selection. So in conclusion, definitely managing candidiasis in ICU remains an enormous challenge. Diagnostic tools, surrogate markers may assist in diagnosing, but with several limitations. So prophylactic fluconazole may reduce the infection rate. Empirical therapy has similar recommendation as targeted therapy, because if you see, empirical therapy choosing depends upon the factors like if the patient is neutropenic, stability of the hemodynamics, whether the patient received azoles or not. To add on definitive therapy, we use the criteria if the patient is having Candida glabrata or cruzi. So almost the selection criteria remains when it comes to empirical and definitive therapy. So IDSA guidelines, definitely for 2016 invasive candidiasis guidelines, echinocandins are the first line therapy, definitive therapy. We can use liposomal amphotericin or fluconazole as an alternative if the patient is not having any mentioned risk factors. So coming back to our case, okay. So what went wrong in our patient? It was a 30-year young male patient with hematolymphoid malignancy, came with some loose motion, blood culture negative, started on some BL-BLI combination with metronidazole. So down the line we got like is culture of the stool positive ESBL, we escalated to carbapenem. Patient down the line deteriorated hemodynamically, persistent fever, died. So here first thing you have to remember, patient was neutropenic for prolonged time. So prolonged neutropenia, we call it as more than 10 days, it's prolonged neutropenia. Profound neutropenia, if the neutrophil count is less than 100, that is absolute neutrophil count, then we call them as profound. So he had a prolonged neutropenia, so then you selected fluconazole as an option. So that is the wrong thing which we have done. So then patient was unstable hemodynamically, okay. So that's also a wrong option, okay. Neutropenic, unstable hemodynamic with empirical antifungal therapy. Here it's a definitive therapy because we have done the skin biopsy which showed budding yeast in that. Okay. So then obviously we could have selected echinocandin as a first option, okay, instead of azole. So that might be the reason for mortality in this young patient with neutropenic sepsis, with fungal infection, with hematolymphoid malignant background. Thank you all. For more updated video on evidence-based critical care medicine, emergency medicine and anesthesia, please watch my YouTube channel and please subscribe. Thank you all.